If you look back 20 or 30 years, a lot of the treatments that were called complementary or alternative therapies, things like acupuncture, exercise, yoga, tai chi, biofeedback, cognitive behavioral therapies, these therapies were all more or less dismissed by the sort of the mainstream US healthcare system. And we had a tendency to like our drugs and like our procedures because the biomedical models of diseases fit more closely with that. It's been fascinating to be in the pain field for the last couple decades and see that the pendulum is swinging very rapidly towards those therapies. Those non-drug therapies that we used to be dismissive of are probably working at least as well, if not better, than a lot of our drugs or our procedures.
What I think our group tries to bring to the picture is the idea that there are patients where there is a different set of characteristics, things like widespread body pain or lots of overlapping pain conditions, rather than thinking about those as 5 or 10 distinct pain conditions, maybe instead thinking about them as a common concept. So rather than addressing each peripheral pain complaint, such as the back pain or the knee pain, thinking about addressing the brain and the spinal cord through other mechanisms.
What is really important for clinicians is that they should look at the whole person and think about maybe using centrally acting agents or centrally acting interventions that target the brain and spinal cord, rather than just going in and sort of like, cutting out the area of the body that seems to be sensing pain.
Chronic pain management is not just the medications you take. It's absolutely a multidisciplinary approach encompassing lifestyle factors like exercise, diet, sleep, definitely in the types of therapies that people are undergoing and the medications that they're taking. And so putting so much value and weight on one specific thing, I think does a real disservice to patients and providers, because it shifts the conversation away from this, contextual big picture thinking that we should have for each unique patient.
I really feel that we've been greatly educated about the multidisciplinary and multifaceted approach to chronic pain. We're also beginning to better understand that long-term opioid use for the treatment of chronic non-cancer pain is probably not helpful for most patients, and both with education as well as other multimodal ways to treat pain, I think we're doing a little bit better job of offering patients alternative as well as more effective ways to manage their pain.
The thing that our current opioid users are telling us is a major barrier to stopping opioids is fear that their pain is going to get worse. And so if we have something that we can give them, a tool like cognitive behavioral therapy, that will hopefully alleviate some of that fear, which is an understandable reaction.
I think in the future we'll start to see more trials and more studies where instead of just randomizing individuals to receive acupressure or a drug, we may actually combine them together.
Can we actually make a tried and true intervention much more effective and engaging for our patients just by adding activities such as daily performing acts of kindness, or thinking about the things that happened that day that made you happy, or using your character strengths in new and interesting ways. All these things can contribute to making our interventions just more enjoyable and hopefully more effective.